good morning and a warm welcome to all the respected participants. My name is Ashish Tukal. I am representing GE Healthcare Cardiovascular Ultrasound segment. Today, we are going to conduct an exclusive clinical lecture on evaluating the role of left atrium in cardiovascular disease on our XP Connect webinar education series powered by Vivid Cardiovascular Ultrasound Technology from GE Healthcare. As the world navigates the unprecedented challenge presented by the COVID-19 pandemic, we are inspired to support healthcare providers around the world in addressing it. Heart disease is now a leading individual cause of disease burden in India. As we all work towards the same cause of healthier India, early intervention is the key, which requires a shift from a traditional way and take a more comprehensive view of treating and handling of the patient. For the same today, we have with us one of the renowned names in the field of echocardiography, Professor Dr. J C Mohan from Delhi. I welcome you, sir. Dr. J C Mohan is a well-known name in the cardiology community and has been contributing immensely, be it educational initiatives, books, training, relentlessly to name few areas. Before we get started, due to nationwide lockdown, there has been a huge traffic load on internet services. If you experience temporary interruption in the transmission, kindly bear with us. We will sort it out immediately and resume. I now welcome the esteemed faculty, Dr. J C Mohan, to address our viewers with his clinical talk on evaluating the role of left atrium in cardiovascular disease. Over to you, sir.
Thank you, Ashish. Let me just get going in a moment. Okay, here we are. Good morning, ladies and gentlemen. We would be discussing today left atrial function, the barometer of cardiovascular health. As you all know that the left atrium is a posterior cardiac chamber situated at the top of the left ventricle, posteriorly separated from esophagus by fibrous pericardium. There is no serous pericardium over left atrium, and hence you don't see pericardial effusion along the left atrial borders. Posterior half develops from sinus venosus and drains pulmonary veins and is relatively smooth. Anterior part of left atrium develops from primitive atrium and is connected to mitral valve and left atrial appendage. The left atrium is separated from right atrium by interatrial septum. The left atrium is an extremely important chamber. It's a dynamic blood transporter. It transports blood from pulmonary veins into the left atrium, then into the left ventricle. It also is an important neuroendocrine organ. It is responsive to stretch and releases many hormones, prominent of which is atrial natriuretic peptide, which causes vasodilatation, which also causes natriuresis, prevents fibrosis, is anti-proliferative agent, and has many other properties. Left atrium also reflexly control the cardiovascular physiology by Bainbridge reflect and Bizold-Zarisch reflect, which means it controls the heart rate, the length of the cardiac cycle, and length of diastole, depending upon the physiological stimuli. And lastly, it participates in atrioventricular synchrony, which is an extremely important part of cardiovascular physiology, both in health and disease. Of late, left atrial function is being recognized as the most promising tool for predicting cardiovascular events in healthy subjects and in patients with heart disease. Essentially, left atrium modulates left ventricle filling and cardiovascular performance. It has three components of function: reservoir function, which occurs during the ventricle, it stores the blood; conduit function in early diastole, where the blood which is coming from the left atrium is moving into the left ventricle; And the third component is pump function or booster function when atrium contracts near the end of diastole to push extra blood into the left ventricle. In addition, as I already said, it is a volume sensor of the heart releasing natriuretic peptides, and it contains receptors for various reflexes. So all the three functions have determinants, or what you call it denominators. Reservoir function is modulated by contraction, RV systolic pressure, LA relaxation, and LA chamber. Conduit function is also modulated by LV relaxation and LA afterload. Contractile function, as is usually the case, is controlled by preload, afterload, intrinsic left atrial contractility, and left ventricular compliance. The gold standard of left atrial function assessment is left atrial pressure volume relationship. This pressure volume relationship has two loops, an atrial loop and a ventricle loop, and it is figure of 8. Unfortunately, there are no clinical means for a clinician to study the left atrial pressure volume relationships. Hence, we study the left atrial pressure indirectly by echocardiography using some conventional parameters and some new techniques like 3D echocardiography and acoustic Speckle tracking. Before we go to left atrial function, keep in mind that Frank-Starling law also operates in the left atrium, and this is one of the reasons athletes have bigger left atrium, because their heart has to do more function for better or increased cardiac output. However, excessive dilatation of left atrium, the atrium gets onto descending curve of the Frank-Starling law, and hence the performance falls. We also have to understand, since we are talking of left ventricle function, left atrial function, we have to talk of left atrial dysfunction also. You can call left atrial dysfunction as atrial cardiomyopathy. Essentially, the atrial cardiomyopathies are of 4 types. Class 1, involving predominantly cardiomyocytes, as happens in lone atrial fibrillation, genetic disease, or so-called isolated atrial cardiomyopathy, diabetes. Then you can have the primarily fibroblastic dependent involvement of the atrium, as in aging and smoking. Most common is a mixed cardiomyocyte fibroblastic dependent atrial cardiomyopathy, which occurs in heart failure, valvular heart disease, and hypertension. The last is primarily non-collagen deposits, which happen in patients with isolated atrial amyloidosis, granulomatosis, and inflammatory infiltrates. Whenever there is atrial dysfunction, atrium enlarges, there is fibrosis, there is electrical remodeling, and clinical effects of these are sinus node dysfunction, atrial fibrillation and other tachyarrhythmias, endocrine dysregulation, hypercoagulability, and chances of stroke or thromboembolism. So the atrial disease is important because these things which happen are not only they reduce the quality of life, but they also shorten the survival whenever there is atrial cardiomyopathy. Now, how do we assess left atrial function to decide whether atrial cardiomyopathy is present or not? There are 3 main ways: volumetric method, Doppler method, and Speckle tracking method, or what we call a strain method. We can assess the transmitral flow, transpulmonary flow, left atrial volumes, and of course, the Speckle tracking can be done. Before we go further, keep in mind one thing, that in health, the total length of left ventricle and left atrium is constant. So in systole, when left ventricle shortens, the left atrium has to lengthen. This is a reciprocal relationship present in health, which actually means if the left ventricle shortens, by 20%, the left atrium will also lengthen by 20% in systole. This reciprocal relationship is lost in disease, and you can detect isolated ventricular disease or isolated atrial disease or dominant variety based upon lack of this reciprocal relationship in disease states. So again, why left atrial function? Because we are now realizing that it provides better window to health and cardiovascular disease. We can understand cardiovascular physiology better and cardiovascular pathology better if we assess left atrial function. For a long time, we have been concentrating or focusing on left ventricle function. Of late, we have been focusing on right ventricle function. And now we add another third dimension or the last frontier of cardiovascular function, that is the left atrial function. Before we go to details of left atrial function, keep in mind one thing, that the long axis of left atrium and left ventricle are not on the same line. They are not parallel to each other. The left atrium and left ventricle have an eccentric relationship, and there is an angle of almost 150 degree when you talk of long axis of left atrium related to long axis of the left ventricle. This is important because if you want to estimate left atrial volumes, you should be obtaining LA focus views which show the maximum length of the left atrium. So here are two examples. On the left side is the standard 4-chamber view. In standard 4-chamber view, left atrium is off axis and its volume is 53 milliliter. The moment you go to the right side, which is an LA specific view, here the left atrial and left atrial systolic volume or maximum volume 75 ml. Look at the difference. There is 30% increased in volume measurement simply because you have moved from a cluster view for LA measurement to a off-axis LA focus view. So as far as possible, try to get LA focus view for LA volumes. How do you get it? Well, the point here is that if the left atrium is, the left ventricle is tilted to your left, then chances are that you would be along the long axis of the left atrium. But typically, this is how we have been doing actually the left atrial volume measurement. Here is I will say standard 4-chamber. In a standard 4-chamber view, remember left atrium is 4. So here the left atrial volume is being measured, and by automatic function we are getting a maximum volume of 70 ml, minimum volume of 27 ml, and left atrial ejection fraction of 60%. We know here that the left atrial volume is increased, left atrial function is normal as shown by ejection fraction. However, keep in mind one thing, that in this view, there is every chance that left atrial volume would be significantly underestimated. You may not underestimate function, but you will definitely underestimate left atrial volume. The left atrial function, as determined by left atrial ejection fraction, is a strong determinant of exercise capacity. In case the left atrial ejection fraction improves on inotropic stimulus, whether in health and disease, it indicates the exercise capacity is good. On the other hand, if the left atrial ejection fraction falls, these are individuals who have lower VO2 max, lower exercise capacity, and people are suggesting that you can find out who are the people who may be candidates for device implantation, assist devices, or cardiac transplantation based upon assessing left atrial function. However, We do measure left atrial volume, and it has been suggested by the ASC 2015 guidelines that you should use biplane area length or Simpson's method for measuring left atrial volume, and normal left atrial volume is 22 plus minus 6 ml per meter square, and it is abnormal if it is more than 34 ml per meter square, except in athletes where even more than 34 can be normal. This is good to measure the left atrial volume because this correlates with the prognosis in all variety of diseases, including diabetes, hypertension, heart failure, valvular heart disease, and so on and so forth. However, limitations of 2D LA volumetry are that there is quite often LA foreshortening. You make geometric assumption that the LA is prolate ellipse, and you do manual tracing. All of these have their shortcomings, and hence you consistently underestimate left atrial volume. Remember, the word is you consistently underestimate left atrial volume. Echo are always lower than what you'll get in 3D or by cardiac MRI. We actually published some study on left atrial volume sometime back in Indian Heart Journal, and we demonstrated that left atrial volume index in Indians is smaller by an average of 4 ml per meter square compared to what has been reported by American Society of Echocardiography. And hence it is important to remember that when we talk about diastolic dysfunction or prognosis for Asian Indians, the left atrial volume parameters would be slightly on a lower side as a dichotomous value. So since there are limitations with two-dimensional volumetry, people have moved to three-dimensional echocardiography. Three-dimensional volumetry gives you total volume, passive or conduit volume, and active or booster volume. How does that happen? Well, we now have dedicated software in the newer machines which are capable of giving all these things. This is an example of left atrial 3D volumetry from older system. In older system also, here you don't have to actually look for maximizing the LA size. The equipment automatically does it once you acquire a 3D image. It gives you the maximum volume, minimum volume, left atrial ejection fraction, and also left atrial output. We have gone further than this, and this left 3D volume, by the way, is greater than what you get by 2D volumetry. However, the latest equipment, especially E95, have gone further than this, and there are dedicated softwares for left atrial function. So when applied, these left atrial function parameters, the left atrial function algorithms give you not only left atrial minimal volume, maximal volume, pre-A volume, left atrial ejection fraction, conduit function, but simultaneously give you left atrial deformation parameters, which means left atrial strain in 3 phases and left longitudinal strain as well as circumferential strain. So as you can see from the curve here, not only you get the maximum volume, you also get the minimal volume, and from there you automatically get ejection fraction. Actually, the curve only is telling you what is happening, and the numbers are one in which we are interested. So all you have to do is get a 4D picture, get a 4D video, or get a 4D image, and from there, once you press upon the left atrial function parameter, you would get everything about the left atrium by these new softwares as present in E95. However, other equipments also are capable of getting 3D left atrial volumes, and these are the pictures from Philips systems. Philips system gives the left atrial volume, 3D left atrial volume by this heart model technique, but it does not give you volume in different phases. It does not give you left atrial ejection fraction, and you will not be simultaneously able to get left atrial strain. So those are the drawbacks currently with the Philips system, but nevertheless it is probably much easier to use to get maximum left atrial volume and quickly decide whether it is normal or abnormal. The other advantage is it gives you left ventricle volumetry and left atrial volumetry simultaneously. This advantage actually is also a big plus point for our Philips system. Having said that, again I said, when you talk about volumetric functions, you should talk about LA, maximum volume, minimum volume, left atrial ejection fraction, pre-A volume, conduit volume, and booster function. All these things are automatically nowadays given by the system along with strain, and that is a huge big advantage. Time has come now to include left atrial function assessment in each and every report, because now it is so simple, so easy, and so less time consuming. So here are again showing you the graph curve, and you can see the three phases: the total volume, which is called left ventricle maximum volume; minimum volume, which is at the end ventricular diastole, and before the P wave and the end of diastole is the booster volume. And from there you can calculate what we call as atrial contribution to left ventricular, the left ventricle filling, or atrial contribution to the left atrial filling. Dr. Luigi Badano has used this technique to give us the upper limits of left atrial volume index. By 3D left atrial volume index, the upper limit is 43 ml per meter square. And in his study, the 2D gave 35 ml per meter square as the upper limit, against what ASC recommended, 34 ml per meter square. Very close, very, very close. And these volume upper limits are valid regardless of the gender, which means if you are using 3D volumetry, remember volumes you will get will be bigger, but these are the actual volumes because these correlate with the cardiac MRI. Here is Dr. Badano's paper showing the left atrial maximum or minimum volume correlating with the CMR or cardiac MR with an excellent correlation and with minimal bias of 7 milliliter. On the other hand, with 2D LA volumes, although correlation is very good between cardiac MRI derived LA volume and 2D derived LA volume, the bias or the limits of agreement are much wider, nearly 2.5 times, 17-18 milliliter. So one lesson which we have learned over a period of time is that 3D LA volumes are to be preferred over 2D LA volumes if available. The caveat is we still haven't decided what would be the upper limit, although we have data from Dr. Badano. And if it is not possible, try to get maximized LA volume from LA focus view using area method. Another important lesson is that the new equipments like E95 are capable of giving you comprehensive left atrial function assessment in a jiffy. And if possible, that would be the way to go for this. That certainly is not future, it is present. But for some of us, that may be future in case we are not keeping pace with time. However, I must emphasize that in case you do not have facility for 3D volumetry, you are not trained for it, your lab is too busy, off-axis LA imaging, as shown here, would give you LA volumes which are close to what you will get by 3D. Here is an example, a true example where by 3D the LA volume is 62 ml, and by 2D single plane I am showing 60 ml, because we tried to maximize the LA volume by getting the LA focused view. However, the volumetry has significant issues. These are: volumes are influenced by loading conditions and show high variability. So, as far as left atrial ejection fraction is concerned, booster volumes are concerned, or total LA volume is concerned, those are important. Those should be measured, but remember they are affected by loading conditions. We are looking at parameters which will be minimally affected by loading conditions, or will be relatively load independent, more robust, showing less test-retest variability. And for that, we move to Doppler parameters and Speckle tracking parameters. The annular tissue Doppler parameter is also provides something about left atrial function. The peak A prime velocity of the mitral annulus is a marker of atrial function, and better is the A prime velocity, better is the left atrial booster function. However, the limitation of tissue Doppler is that it is angle dependent and it is influenced by translation and tethering, which of course we can overcome by using, which would give us strain, and indirectly you can get velocity as well. So let me just show you an example. This is a 47 years male with cardiac amyloidosis. The A prime here is just 2 centimeters. This patient has what we call it 5-5-5 sign. S prime is less than 5, E prime is less than 5, A prime is less than 5. These people have extremely bad prognosis. Here, the A prime of 2 centimeters is telling us that the patient has bad left atrial function. You don't have to go any further than this to say this patient has advanced degree of atrial cardiomyopathy. The A prime has been correlated with prognosis. Here is a study of 96 patients with heart failure. A mitral annulus A prime less than 5 centimeter portends grave prognosis and worse survival in these individuals over a follow-up of 2 years. Here is another example. Typically, there is a reciprocal relationship between E prime and A prime. As the E prime decreases, the A prime tends to increase to compensate for the conduit function. However, lack of this reciprocal relationship tells us that the atrial function has gone to an advanced stage of dysfunction. Here is an example where the S prime of around 7 centimeters per second doesn't tell you the story, but the E prime is 4 centimeters per second and A prime is about 5 centimeters per second, telling us that the reciprocal relationship between the E prime and A prime is lost and patient is moving towards advanced left atrial cardiomyopathy. There are other studies which have shown that people who do not show increase in A prime on exercise, these people have much worse prognosis and tend to develop left ventricular dysfunction over a period of time. We can also use color TDI to get idea about atrial function, and the advantage is that you can do at multiple points and looking at the A prime, which obviously is the mean value and not the peak A prime value as you get in color TDI. Here also the issue has been about setting the normative data, but nevertheless we used to use it, but no longer we are using it as a routine because of noise, the noise which is there in color TDI. We come to acoustic speckle tracking, which probably is the easiest way of assessing left atrial function and which is gaining ground despite the fact that we are still lacking large validation studies. Like we do left ventricle acoustic speckle tracking to get LV longitudinal strain, which is there for prime time use, we are going towards acoustic speckle tracking for assessing LA function, and soon it will be in prime time use. Typically, you should be using two views, 4-chamber and 2-chamber view, and the way you obtain left ventricle strain, you can obtain left atrial strain. Although we know walls are thinner, and hence chances of the through plane motion are more, and that is one of the reasons we need to do more validation studies. But this is how we are moving forward as far as assessment of left atrial function is concerned. Here also, left atrial strain can be measured in all three phases: reservoir phase or reservoir strain, booster strain or atrial contraction state, and also during the early diastole. Here is a cartoon to show that you can get left atrial acoustic speckle tracking strain by triggering either from the beginning of P wave or triggering from the QRS complex. And the maximum strain you get actually is called the left atrial reservoir strain, and at the end, just after the P wave, the strain you get, which is a negative strain, you call it late diastolic strain or atrial contraction strain, or you can call it booster strain. So here is, instead of a cartoon, this is the real picture. You can now see how, like the way you do left ventricle acoustic speckle tracking, you are doing left atrial speckle tracking, and you have the big arrow points towards the reservoir strain, the maximum, and the smaller arrow points towards left atrial booster pump function. Typically at this moment we are concentrating on peak left atrial strain, which is the reservoir strain, because whatever validation data are available with the peak left atrial reservoir strain. The meta-analysis done by Dr. Tom Marwick of the healthy subjects, multiple studies have shown that the average left atrial, peak left atrial strain, longitudinal or reservoir strain, is about 40%, which is almost twice of the left ventricle longitudinal strain. On your left side, the longitudinal strain is shown. The values are anything from -16 to -22. Here values are more like -38 to 41. So twice. So keep in mind one thing, that left atrial reservoir strain normally is twice of left ventricular strain. The technique of tissue Doppler imaging for getting strain is also available, but we are not using it that often because it is angle dependent, time consuming, and there is significant amount of noise. But nevertheless, the technique has good specificity. It also provides strain rate values which are more reproducible. So let's come back to two-dimensional spectrum tracking of the left atrium. We can study the reservoir function, conduit function, and booster function, as I already showed you in cartoon. So let me just show you an example. This is a 65-year male with controlled hypertension. Now this is a 4-chamber view, and if you would note carefully, this is actually LA maximized view. The left atrium, the left ventricle is slightly tilted to the left, but you get a good left atrial volume, and the left atrial volume certainly is increased. But look at the left atrial, peak left atrial strain or reservoir strain, it is 20%. Remember, these values are positive compared to LV strain values which are negative during 20%. And as I told you, typically the left atrial strain should be 40%, and this is 20%. So one thing is certain, this gentleman has hypertensive atrial cardiomyopathy. He definitely has involvement of left atrium because of long-standing hypertension. The arrows point towards the reservoir strain and booster strain. We at this moment are using booster strain mostly for research. I am sure more data will come out and this might become an important parameter of prognosis and diagnosis in future. At the moment, our focus is on reservoir strain shown by this big arrow right in the center, or also called maximal left atrial strain. And as I said, the right ballpark is about 40%, and in this case, it is 20%. Let me just show you another example of a 30-year-old female with hypertension. She has a lane in fourth chamber of 11%, minus 11%, and left atrial peak strain of 12%, plus 12%. Now, the relation have been ideally health twice. The left atrium in this particular lady is involved far more, is affected far more, and hence left atrial longitudinal strain or the reservoir strain is 1/3 of what normal people have it. On the other hand, left ventricle strain is maybe about half or less than half, little more than half of what should be there. What does this picture tell us? This picture tells us that the atrial disease is far more advanced in this particular individual. And this particular lady, when she goes into problem, that is because the atrium is diseased much more. Now, do you remember the left atrial peak strain was about 12%? You can use that to estimate the left-sided filling pressures. So here is a study showing an excellent correlation between global atrial longitudinal strain and pulmonary capillary wedge pressure. And since our patient had about 11 or 12, our patient would have close to 22 millimeter of pulmonary capillary wedge pressure, which means our patient, the one which I showed you, that 38-year female, most likely should have shortness of breath, should have heart failure, should have elevated natriuretic peptides. So not only the left atrial strain tells you about the presence of atrial cardiomyopathy in this case, and this is despite the fact that the left atrial ejection fraction here is 60%. So one thing is certain, that left atrial strain provides incremental value over and above left atrial ejection fraction, and also over and above left atrial volume. It also predicts whether the patient will have elevated BNP or not. If you take a cutoff limit of less than 20% with a reasonable sensitivity of 55% and specificity 77%, you can predict that the patient will have elevated natriuretic peptides simply by doing left atrial peak strain. As I did talk about Dr. Tom Marwick's data, this is the normal range of left atrial strain by Speckle tracking echocardiography. And in this study, it has been 40 plus minus 8%. And what has been said is that the left atrial strain is independent of age, body surface area, left ventricle volume, and also So let me just continue on the same line, showing you another case. 65-year male with controlled hypertension. Patient is asymptomatic. Now we have done a 3D volumetry. The left atrial volume is 62 ml and indexed is 34.5, which is slightly above normal if you go by ASC criteria. However, if you go by the criteria which we have tried to create, probably it is more. However, remember, this is 3D volume, and a 3D volume, the cutoff should be high. So what will be my interpretation, despite the LA looking slightly biggish, but 3D volume, since Dr. Badano said 43 ml per meter square, we'll call this left atrial volume as normal left atrial volume. Look at the left ventricle function. The ejection fraction is 70%. Stroke volume is 74. All you will say is everything seems all right in this gentleman who has hypertension. The echo shows mildly enlarged left atrium, but everything else is all right. The volume wise, everything seems to be okay. Ejection fraction wise, it seems to be everything okay. Let us look at his Doppler study. The transmitter flow at the top shows you probably pseudo normal pattern, probably an L wave, but when you do the E2 E prime, the average E2 E prime is 10.5. It is 14 on medial side, 7 on lateral side. And look at the A prime. The A prime is 13 centimeter on lateral side, 9 centimeter on left side, suggesting that the atrial function is pretty good. And possibly the filling pressures are not elevated. So far so good. With the average E to E prime of 10 in this individual, we could say, well, everything seems to be going all right. But when we look at the left atrial strain, when we look at the left ventricle strain, first look at the left ventricle strain on the right image. In a 4-chamber view, the left ventricle longitudinal strain is minus 24.3. Pretty good upper limit of normal. But look at the left atrial reservoir strain. It is plus 20%. It is half of what should be normal. So clearly this gentleman has evidence of atrial cardiomyopathy. This is most likely hypertensive atrial cardiomyopathy, and it is not borderline. It is not close to, instead of 40, not 35, 33, it is 20%. So one thing is definite, that this patient is one candidate who is likely to develop diastolic dysfunction. If you still don't count that E to E prime of 10.5 as diastolic dysfunction, he has a chance to get into heart failure, chance of developing stroke and atrial fibrillation. And this is the time to be aggressive about all those therapies which can help this individual. It has been suggested that left atrial strain correlates with the amount of left atrial fibrosis. Here is a study to show that in people who have no or minimal fibrosis have a left atrial strain closer to 45%, and once it is 18% or less, it tells you that extensive fibrosis is present. Remember, the case I showed you has left atrial strain of 20%, suggesting that this patient also has developed significant left atrial fibrosis. And that is the power of using left atrial speckle tracking. There are also data to suggest that LA reservoir strain, once it goes below 31%, is a good discriminator in individuals in deciding who will develop events like cardiovascular death and hospitalization for heart failure. Of course, if people have no atrial fibrillation, even below 35% is grossly abnormal. But if people have atrial fibrillation, below 30% is certainly abnormal. There are other data in hypertrophic cardiomyopathy to suggest that left atrial longitudinal strain determines prognosis and hypertrophic cardiomyopathy. Lower is the left atrial strain, worse is the prognosis. Not only that, it can differentiate hypertensive left ventricular hypertrophy from hypertrophic cardiomyopathy. Typically, if the left atrial strain is less than 10%, chances are we are dealing with an individual with hypertrophic cardiomyopathy. And in hypertensive individuals, the LA strains are usually above 10%, more in the range of 10 to 20%. And in normal control individuals, these would be more than 20%, in any case closer to 40%. As I showed in the previous slide, people have used LA strain to predict left atrial mean pressure, taking various cutoffs. The best cutoff remains an LA strain of 19% or less, tells you that the filling pressures are definitely elevated. So this peak longitudinal left atrial strain correlates with left atrial mean pressure very well, correlates with BNP levels, modestly correlates with left ventricular ejection fraction, also correlates to some extent with E2 prime, although the case I showed you of 65-year gentleman with the E2 prime of 10.5 and a strain of 20% shows that the correlation of E2 prime with PLAS is also modest. Remember, the LA strain decreases early on in disease process, so you can pick up some clinical disease and take aggressive measures to prevent patient from going into clinical state of failure. People have done, this is some recent study published last month. It says that if you combine E2E prime as well as left atrial reservoir strain, you can predict elevated filling pressures in patients with coronary artery disease better than when you use any of the parameters independently. Again, suggesting that in addition to E2E prime, which you report regularly in your reports, you should try to report left atrial reservoir strain. It gives good idea to clinicians in which way their patient is likely to go. But we also have to keep in mind one thing, that there are limitations to left atrial deformation imaging. Number one limitation is dependent on image quality, garbage in, garbage out. And other significant limitation is that Speckle tracking for left atrium has not been validated for LA function. At least test-retest variability hasn't been adequately studied. Core lab hasn't decided whether it's a robust parameter, but we are moving in that direction. So what is lacking as far as the Speckle tracking left atrium is concerned? I showed you the from E95 3D pictures telling you everything about LA function in a TIFI. However, the issue is we don't know what is the standardized methodology, whether we should use 4-chamber alone, 4-chamber plus 2-chamber, whether the gating should be at P wave or gating should be at QRS. And people have suggested gating at P is more accurate, but we need more data and more validation. We need better reference values. What should be considered absolutely abnormal? People have said different things, 20%, 23%, 30%, 35%. We need better reference value, and we definitely need robust validation data before we start routinely using it in our practice. At this moment, if you are a smart echocardiographer, you probably will mention LA function. But if beyond LA volume and LA size, you don't do anything else, even then the report is quite acceptable from a regular standard. So, ladies and gentlemen, to conclude, an accurate assessment of LA function remains cumbersome. Left atrial ejection fraction is something which you can easily do, but it is not routinely performed. Newer parameters are interesting, that is tissue Doppler imaging and Speckle tracking imaging. And in tissue Doppler, A prime is important, Speckle tracking the reservoir strain. A thorough evaluation of atrial function may help in early detection of subclinical disease, could refine risk stratification, and could guide therapy, as I showed you by examples, and extend the reversibility of LA remodeling with medical therapy, or the impact of such changes on outcome need further studies, because if the changes come early in the left atrium, reverse remodeling will also occur early in the left atrium. So far, we have data as far as the left atrial volume reduction is concerned. We recently had PROVE-HF study where ARNI showed a significant reduction in left atrial volume index and E to E prime. However, we need to look at reverse remodeling by using Speckle tracking and other tissue Doppler parameters. Thank you very much. I am open to questions.
Thank you for such a wonderful session, sir. So, for the first question is, how to assess LA function on routine machines not having high-end software? Dr. Ketkar from Nasik, Maharashtra.
My suggestion would be at least measure the left atrial size in 2 axes. Try to get left atrial volume by biplane method and try to report A prime. These are easier done. You may not do Speckle tracking, but you should report A prime and its value, the left atrial volume index, and left atrial size at least in 2 views.
The second question is, elaborate on LA focus view, where to keep probe.
Now the probe is same as you do in apical 4-chamber view, which means cursor points towards 3 or 4 o'clock position. You first try to get an optimized apical 4-chamber view, and then try to rotate the probe so that the interventricular septum, instead of being exactly parallel to insonifying beam, comes at an angle. When the interventricular septum comes at the angle and you have rotated the probe little more towards the left side and tilted tilted slightly towards the right shoulder, you will see that the left atrium starts opening. Whenever you visually decide that this now I am getting the maximum left atrial length in end systole, that is the LA focus view. It is not that difficult. The only thing is you have to remember is that you wouldn't get it in a standard apical 4-chamber view. If this is a good apical 4-chamber view where your septum is absolutely perpendicular to parallel to the insonifying being and right in the center, you are not going to get the right LA volume. This has to be tilted. Interventricular septum has to be tilted, and tilted in such a way that the apex is more towards the right, more towards your left, which means towards the right shoulder. The probe will move towards the right shoulder, and then you will get the focus LA volume.
Right, sir. So the next question is, almost all studies of prognosis and mortality had been based on 2D LA volume. Do we now take 3D volume and minus 10 ml to come to the same page as 2D?
This would require, as I already said, this will require validation studies. But the 3D volume, the big advantage is that the test-retest variability can be reduced. It is more accurate. It correlates with the CMR. So my suggestion is very clear. Just add 10 ml per meter square to the LA, to the 3D volume, and use 3D volume in the same way you have been using 2D volume for risk stratification. Instead of 34, 10 means start using 44 ml and above. But remember, we are going to give you India-specific values. We are looking at India-specific data. We just have collected good amount of data actually, and in a multicentric study, we probably would give you answer to that also.
Right, sir. Is LA affected by can we measure LA strain in atrial fibrillation and high heart rate?
Absolutely, you can measure. In a high heart rate you should avoid, but in controlled heart rate you can measure left atrial strain in atrial fibrillation. Actually, the left atrial strain would always be here lower compared to people in sinus rhythm. People have tried to correlate the left atrial strain with the recurrence of atrial fibrillation after cardioversion, formation of left atrial clot, occurrence of stroke, and occurrence of heart failure. So LA strain in atrial fibrillation also is important to find out which atrial fibrillation is how risky.
Right, sir. How to measure left ventricle diastolic pressure by atrial function?
Left ventricle? I didn't get
diastolic pressure.
Left ventricle and diastolic
how to measure LV? Yes, sir.
LV and diastolic pressure.
Yes, sir.
No, left ventricle and diastolic pressure you only measure by cardiac aspiration. That is the gold standard. However, all echo parameters are indirect. You can use transmittal flow, E to E prime ratio, pulmonary vein. You can also use the left atrial reservoir strain, and you will get in right ballpark, but you cannot accurately measure neither mean left atrial pressure nor left ventricular and diastolic pressure. You can say left ventricular and diastolic pressure is elevated. Like the case I showed you that had L wave, I would say left ventricular and diastolic pressure is elevated. And in case the E to E prime is more than 14, I can say it is elevated. But you can't get exact quantity of left ventricle end diastolic pressure.
Right, sir. So do you use echo for elastrin or the machines?
I didn't get it. What do you say?
Sir, the question is, do you use echo-pack for elastrin or the machine?
Machine. We regularly use the machine to get left atrial strain. Actually, the E95 is much easier. That's the easiest. But if you have Philips system, that also you just have to fool it instead of you just tell that this is instead of left ventricle it is left atrium, and it will do exactly the same way. It gives you absolutely same values very quickly. So you don't have to actually do the echo pack. Actually, echo pack is more for research purposes and more for presentations. In day-to-day, when you are doing 40 echoes a day, you should be doing everything online quickly. It takes 1 extra minute actually.
Right, sir. That answers the next question also. Can LV Speckle software can be used?
Mm-hmm. Yes, and
the next question.
Software can be easily used. We do it regularly. You just have to fool the machine and you will get the very reliable values. The only problem is that the dedicated softwares tell you about triggering, whether you can trigger from P wave or QRS, and give you a little more information about other types of strains as well. You also get some area strain of the left atrium from the new dedicated systems.
How to measure LA volume by ellipse method?
Ellipse method?
Yes, sir. Ellipsoid method, sir.
So the LA volume is measured exactly the way you do LV volumetry. Go to 4-chamber view, get a LA focus view, go in end systole, use area length or Simpson's method to get the volume. Do the same thing and go in the 2-chamber view, measure the LA focus and get it. Remember, if you are in a LA focus view, LA length would not change. This issue of area length method using the L minimum only comes when you are not using focus views. If you are using LA focus view, you just can average the 2-chamber and 4-chamber volume. That would give you the exact LA volume. Although many machines have dedicated LA volume system also, they automatically will calculate by area length method the volume taking L minimal. But L1 and L2 would always be same if you are taking a focused LA view. There is no difference.
Will using triplane mode be helpful also instead of just 2D mode?
Absolutely, it will definitely be helpful. But remember, at least when you take this thing, when you are recording it, try to get the best left atrium. The best picture. If the picture is good, the triplane is a very good way of getting left atrial volume.
The alignment is the most necessary part, and in some of the machines we cannot align LA in the software. So will it still give a right value?
Yes, in 3D it will give a right value. In 3D it will give a right value. You may or may not align, it still would give you the right value.
We know LA normal values in plaques view, but what are normal LA size values in 4-chamber view?
Well, the people have given values. We don't rely much on that, but grossly when they exceed 5 centimeters in either side, you start saying that the left atrium is enlarged. So whether you talk mediolateral, superior-inferior, exceeding 5 centimeter means left atrium is enlarged. That is how I have been practicing all my life.
Right, sir. Role of volumes in a practice in patients with MR.
Yes, even in a patient with MR, LA volumes have prognostic significance and also need for prophylactic mitral valve repair or replacement. It has been suggested by many studies that if the LA volume exceeds 60 ml per meter square, regardless of the symptomatology, these people should be operated.
Right, sir. That's dysfunction in fibrillation.
Pardon?
The diastolic dysfunction in atrial fibrillation patients. How to
Diastolic
assess?
dysfunction in atrial fibrillation, I think in transmitral flow you rely on deceleration time. And take the deceleration time of the longest RR intervals or take the average of 10 beats, and that is the best. The second best is E to E prime ratio, although we know that this has a modest correlation. These are the two ways of getting, even E to E prime also is reasonably good, but deceleration time probably scores overall in atrial fibrillation. So if you have the longest RR interval, if the deceleration time is measured correctly, it will tell you more than 250 is abnormal relaxation. If it is less than 150, it is severely elevated LV film pressure. And between 150 to 250, this is maybe normal or it could be pseudo-normal, and you may have to rely. But remember one thing, atrial fibrillation always means presence of diastolic dysfunction. Always. All we are trying to say is grade it further.
So in the multi-sector study, speckle tracking will not participate. So can speckle tracking can be used in any?
And it can be used in, sorry, the voice is cutting.
Can we use speckle tracking from anywhere?
Yes.
So there was a multi-sector study in Europe where some of the participants has not participated and their strain parameters has not been accepted. So can the strain study can be used in any machine?
Yes, it can be used in any machine. The inter-vendor difference is much less, and usually the NOR study, which is the normal value study of Europe, had a lowest LV longitudinal strain of minus 18.6, and in that study multiple machines were used, but they used a core lab to arrive at a conclusion. You can use any machine. The difference is very small. Inter-vendor differences are very, very small, less than 2%.
If we get Doppler parameters for function, but normal LV longitudinal strain and reduced LV strain, can we say that we are dealing with LA cardiomyopathy?
Absolutely. Now then you would have to find out the cause of this atrial cardiomyopathy, whether it is age-related, low atrial fibrillation, diabetes, hypertension, amyloidosis, sick sinus syndrome. But there is no doubt that this is an individual who has atrial cardiomyopathy. Whether primary or secondary, you would have to do further tests to find out.
What is the role of LA function in prognosis?
LA function in? The voice is breaking.
Mitral stenosis.
LA function in mitral stenosis, the people have studied actually LA appendage function in mitral stenosis suggests who will develop clot and who will not develop clot. But LA function as such, I am not aware actually of any great study where LA function has been studied. We have studied pulmonary vein flow pattern mitral stenosis before and after valvotomy just to show that what happens to these individuals when mitral valve has been opened. Having said that, the people in mitral stenosis have calculated what is called left-sided atrioventricular compliance or the net atrioventricular compliance. That is a good parameter of LA function in patient with mitral stenosis. Normal left atrioventricular strain is 4 to 6 ml per millimeter of mercury. If it is less than 4 ml per millimeter of mercury, it suggests that left atrium is stiffer and it is diseased, and that these people have more symptoms, more gradients, more pulmonary hypertension, and have worse prognosis.
Assessment of LA functioning without AF. So the atrial fibrillation will the
No, atrial function, the atriation does reduce the left atrial strain per se, so the values have to be corrected by about 5%, the absolute value. So if for lower limit of normal for sinus rhythm is 35% for LA reservoir strain, for atrial fibrillation it will be 30%.
Right, sir. So, sir, what will be your key message to the audience, sir?
My key message would be that in your reports, if you are an echocardiographer, in your reports, please create a paragraph for left atrial function. Create a paragraph for left atrial function and try to mention something about left atrial function. The minimum thing which should include is A prime, both medial and lateral and average, left atrial size, left atrial volume, index left atrial volume, and if you have facility, you should measure left atrial global strain and place it there. It is actually much simpler than is thought. You might say that are we jumping the gun by talking so much about LA function? Well, it is no. The point is we have to move forward. For science to move forward, we need to do things which we were not doing yesterday or day before yesterday. We do these things, clinicians will get more interested. They will look at their patients in light of the findings which you have reported, and then they will try to correlate, and they will find the value which left atrial function gives in assessment of their patients.
Thank you very much, sir, for the very information. We have got greater reception from audience. I'm sure the clinical cases are going to help us in their practice. Thank you once again. A big thank you to all the viewers for your continued support. Stay tuned for our next webinar session, which will be announced soon. Thank you very much. Thank you very much.
Thank you, Ashish. Thank you very much. Thank you, everybody.